imaging of cranial nerve, why is it important for an ophthalmologist? It's a cornerstone for many people interact together. It's a eye is a point where the patient 90%, 90 to 95% of the time they meet the ophthalmologist as a first referral doctor. So it might be due to neurology problem, or it might be due to ENT problem. It could be many departments working together. Can you switch off the lights? Everything will be images. Postprandial, if somebody wants to sleep, it would be also easy for them. So cranial nerve, as per undergraduate teaching, 12 cranial nerves, though we would have learned in our internship, how much in our day-to-day practice, being an ophthalmologist, you would be more concentrating about up to maximum of 7th or 8th cranial nerve. Beyond that, you might also not be worried. I think in one of the talk, Dr. Ambika ma'am showed one case, lower cranial nerve problem causing a ophthalmic symptoms. So particularly olfactory and optic nerve is an extension of central nervous system. It is not considered as a cranial nerve. It is an extension of the central nervous system. So majority of the pathologies will be associated together. So any problem in the optic nerve, always you should look into the context. You should rule out any abnormality in the brain. You should also have a vicious watch to look for any abnormalities future happening in it. As I said, 12 cranial nerves. Everybody convinced with the 12 cranial nerves? Ophthalmologists, you are interested in what are the cranial nerves? Postgraduates? Huh? Stand and tell me. Which are the cranial nerves which you want? Huh? Huh? Postgraduates. So only 2 you want? Huh? Only second. Okay, right. So since the topic is over here, cranial nerve, whenever you consider any abnormality, when you clinically evaluate, patient could come with an pain over the eyes or visual loss. When you think of imaging, this is an era of evidence-based medicine. So whenever you diagnose anything clinically, patient wants a confirmatory either by supportive investigations. In radiology, as my previous speakers have spoken, many from X-ray, CT, ultrasound, MR, many things are there. Particularly in the context of cranial nerve, the modality of choice is a MRI. The full form of MRI for the postgraduate is magnetic resonance imaging. It comes in various strength, starting from 0.3 Tesla to 3 Tesla clinical applications. For picking up of these cranial nerves, minimum requirement is a 1.5 Tesla. So cranial nerve, any pathology to picked up best is a MRI. What is the difference? Why, when we need to use a CT, or what is the role of X-ray in the present era? If you ask, in opthal practice, only in a foreign body or anything, X-ray has no role, except in the case of a foreign body. CT only in an acute setting. For bony pathologies, only CT will be helpful. Otherwise, more than 95 to 99%, it's an MRI. When we speak about an ultrasound, we tell this is an extended stethoscope. Particularly if you ask for a neurologist, MRI is an extended stethoscope for them. Neurologists, majority, after clinically localizing it, 95 to 99%, they would request an MRI. This is an extended stethoscope for the neurologist and neurosurgeons. So there are 12 cranial nerves, olfactory nerve, optic nerve, then 3rd to 12th nerve. This is a MRI sagittal sections. Coming to just sagittal section, MRI, what is the difference? Another thing, MRI you could acquire in 3 different planes. Sagittal, axial, and coronal. 3 planes are there. If we are seeing from the front means it's a coronal. From the side means sagittal. Axial means just like how we chop the vegetables or a fish. In some movies, they will tell, like Vajramina, cut pandra mari, like an axial, in which location the pathology is. So this olfactory nerve is in the frontal region. Any pathology in the frontal lobe or in the frontoethmoid region will cause a anosmia, important problem. Next is optic nerve, which you all will be familiar. It has different components. I'll tell you about the anatomy. Next, coming to the 3rd to 12th nerve, it extends from this is a sagittal MRI of the brain, midbrain, pons, and medulla. Majority of the vital functions like cardiorespiratory, breathing, heart is located over there. Likewise, cranial nerves are also located over here. So majority patient will present with a cranial nerve palsy with a contralateral weakness or anything. If there is a brainstem problem is there, patient could be on ventilator. So these are the 12 cranial nerves. Everybody would be aware. Majority of our interest or pleasures, if we are happy on seeing any scenic places or listening to good music or having a good food, it's all because of cranial nerves. If any problem happens, our life would be difficult. Somebody without a vision is a pathetic. So if you're not able to hear, we put a hearing aid. Taste, if you are not comfortable, if you are not able to appreciate the good food taste, life is very painful. So the cranial nerves are crucial for all majority of our pleasures, particularly in the craniofacial region. As I said, many medical departments interact over the cranial nerves, like an ophthalmologist, neurologist, ENT surgeon, like a surgical oncologist. Whenever after clinically seeing the patient and eliciting the history, localizing where the problem is, next comes the investigation. You should be aware what modality to be asked, because as a developing country, we need to use the resources optimally. Rather than wasting the patient's money, you will lose the patient also. So CT mainly for the bony anatomy or for bony destructions. Otherwise, for appreciating all cranial nerve pathologies, everything, MRI, majority of the time with contrast. Okay. MRI, whenever we're doing an MRI, you should specifically mention if you ask for a cranial nerve, sometimes in some places, radiologist might not be there. Only the technician might be there. So if you mention specifically what cranial nerve you want, what pathology is there. Otherwise, routinely what they do is a 5 mm cut or a 10 mm cut, which might miss these abnormalities. You need a thinner cut. So if you want a optic nerve, if you want a oculomotor nerve, if you want a 7th, 8th nerve complex, thinner sections of that level needs to be done, which is called as an high resolution MR, thinner section, 1 mm section or isotropic imaging. Likewise, when we do a CT, HRCT, high resolution CT for the like a neural foramen, where the cranial nerve exits. As I said, MR is a modality of the choice. These neurovascular conflicts could be better appreciated with an MRI. For postgraduates, majority of the time, patient would have met some other people or a neurologist would have referred for an ophthalmologist to be aware how to interpret an MR. To watch a movie, you need different types of persons, like an hero, heroine, comedian, some villain should be there. Likewise, MRI has got different sequences. So after applying these different sequences, you identify what is the nature of the lesion. So MRI is good for soft tissue structures. CT is good for bony structures. When you see, now the focus is only on ophthalmic and cranial nerve and in the brain. The brain anatomy, where is the gray matter? Where is the white matter? Which is outside, which is inside? Gray matter is outside, white matter is inside. Okay. This is a axial images. These are axial. We are cutting the brain like a slices, like how we cut the fish or anything, cutting the brain. These are the axial images. Okay. You see, this is a midbrain. The important thing about radiology is you need to know about the anatomy. This is midbrain. As I said, cranial nerve 3 to 12 will be from the midbrain to the medulla. This is the midbrain. This is the pons. So these are the axial cuts. As I said, different sequences are there. You need to identify what plane it is, whether it's axial plane, coronal plane, or a sagittal plane. Only 3 planes are there in an MRI: axial, sagittal, coronal. Okay. Next, coming to the sequence. There are, as I said, different players in the movie, different sequences. From an ophthalmologist perspective, you know at least 3 or 4 sequences. That is more than enough. First one is a T1 weighted image. T1, where the brain, the gray matter, white matter will be better delineated. As you said, gray matter will be outside, white matter will be in the center. CSF, brain is a structure which is around 1.3 kg in female, 1.4 in male, 70 to 80% is water. The MRI picks up the images with the help of water. So brain contains water within the ventricle, which is a CSF, cerebrospinal fluid. In a T1, how to identify a T1, different characters in a movie. If the CSF, you will be able to identify the ventricle. If the fluid in the ventricle is black, it's a T1 weighted image. Okay, this is the 4th ventricle, fluid is black. This is the cisterns. This is quadrigeminal cistern, ambient cistern. Fluid contains cerebrospinal fluid. If the fluid is black, it's a T1 weighted image. This is an axial plane, T1 weighted images. Okay. Next, what is the role of CT? I told CT, we will not be able to, unless you adjust the window, as previous speaker was telling, you need to adjust the gray and white matter. Otherwise, you will not be able to differentiate. It is good for picking up the bony abnormality. So this is a internal auditory canal. These neural foramens, these foramen where the cranial nerve goes will be better picked up with an CT. If the foramenal widening is there, we could identify the pathology. So if you think any cranial nerve pathology, first modality of investigation is an MRI. Only if you suspect any fractures or any bony pathologies, you should ask for a CT. So this is another important sequence in a cranial nerve imaging. Here you see the same. This is also the axial plane. Okay, you see the midbrain like a arch shaped. This is a crus cerebri. Midbrain is arch shaped. This is pons. Anterior to the pons and the midbrain will be the CSF. If CSF is black in color, it's a T1 weighted. That character is T1 weighted image. If CSF is bright, it's a T2 weighted image. CSF is bright, it's a T2 weighted image. So coming to cranial nerve imaging, you need to have a high resolution. You should exploit the water present in the brain. High resolution T2 weighted image with a thinner cut. If you're not writing in a request, it's a cranial nerve, they might do a 5 mm, sometimes they might miss the cranial nerve itself. So only if it is an isotropic 1 mm section, we will be able to see, or a 0.6. So this is a thinner section, high resolution. Different machines have different sequences. From your perspective, high resolution imaging is required. Heavily T2 weighted image. One is called as a constructive cis sequence or a fiesta. Okay, next coming to, we'll see individual cranial nerve. What is anatomy, pathology, how to pick it up, in what clinical scenarios you encounter in your day-to-day practice. As I said, olfactory is the first cranial nerve, important, responsible for our smell perception. So you encounter any patient complaining of ophthalmic problem with a smell abnormality in your clinical practice? Visual problem with smell abnormality or reproductive abnormality? Huh? Kalman syndrome. Okay. What are the components of it? Okay. Anosmia, hypogonadism. Okay. Sometimes if any tumor is there over the olfactory region, like esthesia neuroblastoma, patient can have a squint, proptosis. Okay. So coming to anatomy, this is a olfactory which is located in the frontal region, basifrontal region. Through olfactory filaments, it supplies the roof of the nasal cavity through which we perceive the smell. This is the olfactory bulb which goes posteriorly into the perforated substance. Okay. Next, another plane I will introduce in an MRI. This is a coronal plane. Just seeing from the front, I am speaking in front of you. If you're seeing me from the front, is a coronal plane. Axial is you're chopping it. Coronal is like how we take a photo from front. This is a coronal plane. Your orbit will be well seen on a coronal plane. When you're looking for an optic nerve abnormality, you should see in a coronal plane, which is well appreciated, particularly optic neuritis. So since we are in the first cranial nerve, this is a frontal lobe. Frontal lobe, this sulcus is olfactory sulcus. Medially is a gyrus rectus. Laterally is the orbital gyrus. From there, tiny filaments goes. That is the olfactory bulb. If you see, this is the olfactory bulb. Iso-intense gray-like structure. Very small. Okay. If this olfactory bulb, normally it should be seen. If any pathology over here in the cribriform plate, the bony lesion, bone over here is a cribriform plate. Any pathology, bony problem, any tumor over here, which could destroy this, patient will not be able to perceive the smell. Orbit is very close over here, medial rectus, superior oblique. If a tumor is expanding into the orbit, patient will have a lateral deviation, squint. Okay. This is a normal olfactory bulb. This is normal olfactory bulb. This is absent olfactory bulb. As somebody told, Kalman syndrome is a hypogonadotrophic with hypoplasia of the olfactory nerve. Okay, normal olfactory beyond the frontal lobe. How Dr. Lokesh showed a meningocele. small protrusion beyond the frontal lobe is the olfactory bulb. It will be like similar to a gray matter. So one is first whether we should visualize nerve is there or not. If the patient complains in addition to ophthalmic symptoms, any smell perception abnormality, you should look into the frontal lobe olfactory region. Next, as I said, is a mass lesion in the frontal lobe, which could, you see there's a mass in the basifrontal region, which is herniating into the ethmoid sinus into the medial aspect of the orbit. Compared to the left orbit, if you see, right side orbit is laterally deviated. This patient, sometimes Indians are very tolerable. They will come at a later stage. Usually, they could have presented earlier. Headache, they would have taken over-the-counter medications. They would come at a later stage. கண்ணு மட்டும் லைட்டா பின்ன ஒரு சைடா போயிட்டு இருக்கு சார் அப்படின்னு சொல்றாங்க நான் பேசுறப்ப அப்படின்னு. So when you evaluate this is a basifrontal mass extending into the frontoethmoid junction, causing a lateral deviation of the eyeball. This is an olfactory neuroblastoma. This is an olfactory meningioma. Any pathology in the basifrontal region can cause pressure over the medial aspect of the orbit. Okay, you see, this is another patient, sinonasal carcinoma. Malignancy over the frontoethmoid region, causing destruction of the both medial wall of the orbit, extending into the orbit. These are the terminal stages. If you pick up at an earlier stage, it is much better. So this is how olfactory will be associated with the ophthalmic symptoms. Next, your important cranial nerve is the optic nerve. Nobody wants to lose their vision. So anything in the optic nerve should be picked up early. So this is an axial plane. To reiterate, this is an axial plane. This is one character in the movie, T1 weighted image. If the CSF is bright, it's a T2 weighted image. If the fluid is bright, it's a T2 weighted image. This is also axial. This is also axial. This is seeing from the side, sagittal plane. So fluid in the eye, fluid is there in the anterior chamber and posterior chamber. That fluid also will be bright in color. Okay, this is T2 weighted image. If the fluid is bright, T2 weighted image. Beyond that is the optic nerve. So optic nerve is a gray matter structure, will be centrally located, covered by a CSF on both sides. Normally, it should be straight. If you see here, there is prominent. So as previous speakers spoke about IIH, and only if it is clinically, patient is having papilloedema, fundus is showing papilloedema, then other symptoms are there. It needs to, otherwise, MR imaging wise, many a times we see perioptic sheath prominence, which is an imaging feature of a papilloedema, always may not correlate clinically. Next is a coloboma. Next abnormality, though you clinically appreciate, there is a defect in the chorioretina in the posterior aspect, protrusion of over here. Posterior chamber fluid is herniating. Sometimes optic nerve could be aplastic or dysplastic. Completely, there is one syndrome called as septo-optic dysplasia. Septum pellucidum will be absent and optic, I'll show some of the images. Optic neuritis, this is an important thing. Normally, optic nerve will be gray matter surrounded by the CSF, which is white in color. When the entire optic nerve is bright, it is optic neuritis. Sometimes, if it is an acute setting, it will be enlarged. That could be effacement of the perioptic CSF space. If you give a contrast, there could be enhancement. This is optic neuritis. If you identify an acute setting, sometimes it could be reversed with your medical management. So identifying at an earlier stage and correlating with images is much more important. Papillitis is a very early form near the optic, near the disc level. If it is inflamed, it's a papillitis. There are many causes for optic nerve pathology. One important thing is optic neuritis. Rarely, sometimes infarct could also can happen. This is a T2 weighted image. This is a diffusion. You will not be worry much about it. Sometimes infarct will be picked up. Infarct and infection could be picked up with this. This is an ischemic optic neuritis, which could happen sometimes with some neurointerventions or some problems to the ophthalmic artery. Okay, next, another important thing you would have seen so many talks about NMO, multiple sclerosis. One important cause of optic neuritis is demyelination. One is a multiple sclerosis. Multiple means multiple episodes. Neuromyelitis optica is a DeVick's disease, is a slightly severe form of multiple sclerosis. Patient will have a poor prognosis. So how to differentiate? Usually multiple sclerosis will have short segment lesions, whereas neuromyelitis optica will be a long segment lesion. Spinal cord involvement also will be more than 4-segment involvement. Multiple sclerosis, it will be a short segment lesions. Prognosis wise, neuromyelitis optica has got a poor prognosis. As I said, this optic nerve congenital abnormality could be associated majority of the time with the brain pathologies. Normally, frontal on brain has got ventricles, which is a frontal on, third ventricle, lateral ventricle, third ventricle, and fourth ventricle. Both sides, lateral ventricle will be separated by a septum. It is called as a septum pellucidum. If the septum is absent, if both sides fused and form a single cavity like this is a septo-optic dysplasia. This patient could be associated, optic nerve also will be hypoplastic or aplastic. Next is a optic atrophy. Normally, optic nerve will be like a target sign. Centrally will be the gray matter, outside will be the CSF, which is bright in color. This is a coronal weighted image. This is a stir coronal. You see, stir means short-term inversion recovery sequence. Particularly for the optic nerve, you need to ask for orbit imaging. You need to ask for this sequence because scalp contains more amount of fat. Orbit also, there will be more amount of fat. Everything will be suppressed. So anything which contains fluid or pathological will be bright in color. So normal optic nerve is a gray surrounding CSF. Here you could see there is a thinned out optic nerve. CSF is prominent. Compared to caliber of this optic nerve and this, it's thinned out. This is thinned out optic nerve secondary to optic atrophy. Another pathology, wherever anything is there, common one is a congenital abnormality. Next is an infection. Next is a neoplastic or a traumatic etiology. These are the common pathologies which can happen in any organ in the body. Coming to cranial nerve also, this holds true. The important problem in the optic nerve about neoplasm, one is an optic nerve glioma, next is a meningioma. Optic nerve glioma is an intrinsic pathology arising from the optic nerve, whereas meningioma is from the sheath of the optic nerve. So you see, this is a normal optic nerve. This is the axial plane. This is a stir coronal. The sequence which you need to ask for optic nerve is a stir orbit imaging. Normal optic nerve will be gray in color surrounded by a CSF. You see, this optic nerve is significantly enlarged and thickened. This axial also, it is thickened. So this is a uniform enlargement, fusiform enlargement of the optic nerve. This is secondary to glioma. Sometimes it can extend posteriorly also to involve the optic chiasm. How to differentiate this from a meningioma? Meningioma is from the covering. Brain has a covering of a pachymeninges. Meningioma arising from the covering of the brain. Likewise, this optic nerve is an extension of the brain. Is arising from the covering, perioptic sheath. So this appearance is called as a tram track appearance. When you give a contrast, optic glioma also enhances, meningioma also enhances. But meningioma, it will be intense enhancement. Enhancement in a glioma will be less. Okay, the age group also you can differentiate. Optic nerve glioma occurs in a younger age in a children. Meningioma occurs in an older age. The important, it is associated with NF1. Optic nerve glioma, neurofibromatosis 1. Meningioma is associated with NF2. When it is confined into the intraorbital portion, it's an optic nerve glioma. When it extends posteriorly, optochiasmatic, compared to optic nerve glioma, optochiasmatic glioma is more common. You see, from the chiasm, it extends to both sides, optic radiation. You could see this is optochiasmatic glioma. These are all low-grade gliomas. Compared to optic nerve glioma, this may not enhance much. Depending upon the grade, WHO grading of glioma is there, from grade 1 to grade 4. Depending upon that, enhancement varies. If it is a lower grade, enhancement will be less. If it is higher grade, it will be more. Okay, when a chiasm will be located in the suprasellar region, extending posterolaterally up to the lateral geniculate body. This is a optochiasmatic glioma. So what are the pathologies in the suprasellar system? Contains a CSF. Any exudates, like an infective tuberculosis exudates or pyogenic meningitis exudates, which can cause inflammation surrounding the optic chiasm. This is a tuberculoma involving the suprasellar cistern. Another thing, when multiple cranial nerves are involved, you see these are post-contrast images, like a cranial nerve imaging. Whenever they ask, when the radiologist calls you and tell they need to give a contrast, it's a must. So many pathologies, sometimes if it is very subtle, which could be missed on a plain imaging. If it is presenting like a mass lesion, it could be picked up on a plain MR, otherwise which could be missed. So always contrast is a must. This is when multiple cranial nerves are involved. So when we give a contrast, you could see this is a case of a Tolasa syndrome. So this is a post-contrast axial T1 weighted images. Likewise, after giving contrast, they will do 90 to 99% T1 weighted images only. Sometimes rarely flare. You remember post-contrast is only T1 weighted images. There is no T2 post-contrast. This is a post-contrast T1 weighted images in the axial plane. You could see this is a suprasellar region. This is a normal cavernous on the right side. Here you could see the thickening, which is extending to the orbital apex. This is an inflammation extending from the cavernous sinus to the orbital apex, even into the intraconal portion. This is a case of a Tolasa syndrome, secondary to usually paranasal sinus infections. It extends over there. So other pathologies which could occur, cause optic nerve symptoms, is the important vascular structures located adjacent to the optic nerve is the internal carotid artery. This internal carotid artery aneurysms can cause compression over the optic nerve. Some patients, if it presses over the third nerve, they can present with the ptosis. If it is completely compressing, they can present with the diplopia, so many symptoms. Okay. MRI vessels will appear as a flow void. We call it as a flow void. Normal gray white will be like this. These are the blood vessels. This is basilar artery. This is internal carotid artery. Normal vessels should be like a tubular structure. If it is enlarged, it is called as an aneurysm. This is a post-contrast images, shows an aneurysm with a thrombus. Okay. Next, this patient is a case of a retinoblastoma. This is a posterior chamber. In the posterolateral aspect, you could see a soft tissue intensity lesion. When you give contrast, it enhances. Sometimes it can extend to involve the optic nerve also. It can extend to the brain also. Retinoblastoma. You could see the entire posterior chamber is filled with a soft tissue density extending posteriorly to involve the optic nerve. Up to the chiasm, it has extended. I think this has been already been spoken well. This is a papilloedema. At least if you remember this is the imaging appearance of a papilloedema. Perioptic sheath prominence, there could be a flattening or a cupping of the optic disc. Vertical tortuosity can happen. This is how you need to interpret an optic nerve. This is a normal target sign of the optic nerve. Optic nerve will be a gray matter structure. Surrounding CSF will be white in color. When this is lost, it is optic neuritis. In an acute setting, in an acute patient presenting with a optic, you're suspecting an optic neuritis with a visual loss, there will be enlargement of the optic nerve, hyperintensity with a loss of perioptic CSF space. The target sign will be completely lost. When it is a long-standing, it's gone for a chronic case, optic atrophy happens, the nerve would be thinned out. Perioptic sheath would be more prominent. Exaggerated target sign. Okay, the nerve would be very thinned out, surrounding CSF will be very prominent. Papilloedema could be unilateral or bilateral. Many a times, MR papilloedema doesn't correlate with clinical papilloedema. Okay. Next is the oculomotor nerve. Next, all cranial nerves will arise from midbrain to medulla. So it could be associated with, sometimes with neurological abnormalities, like a patient could have hemiplegia or hemiparesis or associated other cranial nerve involvement. This is at the midbrain level. How to differentiate midbrain from a pons? Midbrain is like an arch shape, like a cleft. Okay, pons will be like a smooth. How to differentiate midbrain from a pons? In the axial section, this will be like a cleft, like an arch shaped. This is an interpeduncular cistern. This oculomotor nerve extends anteriorly, extends from the anterior aspect. It goes between the, in the MRI, blood vessels will appear as a signal void between the superior cerebellar and the posterior cerebral artery. So when it goes over there, any pathology like an aneurysm or a dilatation, it will compress the oculomotor nerve. The patient can present with ptosis. This is a third nerve nucleus, which arises from this is a sagittal plane in the midbrain. Midbrain has two colliculus. One is a superior colliculus, other is an inferior colliculus. Third nerve will be at the level of the superior colliculus level. So what are the pathologies? This is a T2, heavily T2 weighted sequence. The cranial nerve sequence which you need to ask for is a cis sequence or a heavily high resolution T2 weighted sequence. This is a midbrain level. Anteriorly, oculomotor nerve goes. This is Basilar artery normally will appear as a flow void, divides into both posterior cerebral artery. Just before the bifurcation, the superior cerebral artery. Your oculomotor nerve goes in between it. So any problem over here in the PCA, it will compress the oculomotor nerve. Patient can present with a ptosis. Okay, what are the pathologies? Starting from its origin to the brainstem, down to insertion into the oblique or recti muscles, what are the problems can happen? When it happens in the parenchyma, the commonest is the ischemic event in the brain. In fact, this is at the midbrain level. If you identify any neurological deficit with that, it is an ischemic event. So there is an infarct in the midbrain. This is another sequence called as a diffusion, restricted diffusion over here. Okay, there is an infarct in the midbrain. This is a T1 weighted image. This is a cavernoma. Usually, vascular problems are common for the parenchymal pathologies to cause the oculomotor nerve palsy. Next, coming to the cisternal, you see over here, normally blood vessel will appear as a flow void in an MRI. When it is enlarged, it will cause a adjacent structure compression. This is at the midbrain level. This is a posterior cerebral artery dilatation. When a dilatation happens, we call it as an aneurysm. So it compresses on the adjacent oculomotor nerve. Patient can present with a ptosis. This is aneurysm. Sometimes if it arises from the PCOM, posterior communicating artery at the ICL level, it compresses the oculomotor nerve. That will also cause ptosis. So if the ptosis appears, if you pick up early and treat early, it would recover. If the nerve loose, we have transplant for many organs. If liver is damaged, kidney is damaged, heart is damaged, we can transplant. Brain, once it is damaged, it cannot be. Likewise, your cranial nerve, once it is gone, it's gone. So any abnormality, if you treat either optic neuritis or ptosis, if you identify early, if you treat, you could avoid majority of the complications. This is uncal herniation, mass effect. This is any problem in the brain. This is a subdural hemorrhage, which is causing herniation of the temporal lobe and compressing over the oculomotor nerve over the crus cerebri. Sometimes, as I said, after going with the ischemic events, next is the neoplastic etiology. Important tumors in the cranial nerve is a schwannoma. Schwannoma, which arises from the Schwann cells surrounding the cranial nerve. This is a third nerve schwannoma. Compared to seventh or eighth nerve, other schwannomas are relatively less. Since we get at many places referral, this is a oculomotor nerve schwannoma. Next come usually these 3, 4, 5, 6 cranial nerves should be examined together, should be interpreted together, because this goes in the wall of the cavernous sinus. Cavernous sinus is a structure on either side of the sella. Sixth cranial nerve and internal carotid artery goes through the cavernous sinus. Rest of the cranial nerves goes through the wall. This is a case of ophthalmic. Many a times migraine, if you image, it will show a non-specific white matter abnormality. Likewise, this patient, these are all case reports. Isolated enhancement of the third nerve, which could happen even in a migraine. Next, another cranial nerve from MBBS. This is a cranial nerve commonly asked in the MCQ, which exits dorsally. This is located at the level of inferior colliculus. This is midbrain. At the lower midbrain level, this is located. So this is an axial T2 weighted, heavily T2 weighted sequence. This is a midbrain at the lower midbrain level, inferior colliculus level. It goes through the quadrigeminal and ambient system. So any problem in the midbrain level, it could affect, or any problem in the cistern, like a ambient or a quadrigeminal cistern, or in the interpeduncular cistern, it could affect the trochlear nerve. This is one of the longest course. After 6, this is one of the longest course cranial nerve. Third nerve nucleus is located over here. Fourth nerve nucleus is located. This is the midbrain. This is the superior colliculus. This is the inferior colliculus at the lower aspect of the midbrain. So, as I said, majority will be the vascular problems. One, it could be an infarct or hemorrhage. So, predominant hypertensive hemorrhages happen in the basal ganglia. Next is the brainstem. Okay, hemorrhage or cavernoma can happen in the brainstem, which could present with a cranial nerve palsy. Sometimes trauma also, frontal bone fractures can cause diffuse axonal injury, which could cause a cranial nerve palsy. This is a cavernoma. Cavernoma is not a malignant tumor. It's a vascular tumor. It's a don't touch lesion. It should not be operated. How to identify? This is like a popcorn, like a pepper pot appearance, varying signal. Surrounding, if you see a black region, it's a hemosiderin. If it is having a black capsule, it's a cavernoma. These are all multiple sequences. You need not worry. If you know this sequence, it is enough. This is a T2 weighted or a stir sequence to identify early problems. Okay, this is angiogram, TOF angiogram. These are the variety of pathologies where fourth nerve could be affected. This is a cavernoma involving the lower midbrain. This is a lipoma involving the ambient and quadrigeminal cisternal junction, because this fourth nerve arises over here and goes through the ambient and quadrigeminal cistern, which will be compressed by this lipoma. Any inflammation will be better picked up with a contrast. This is an orbital pseudotumor which compresses the orbital apex and the anterior aspect of the cavernous sinus. Next is the trigeminal nerve. Trigeminal nerve, where neurologist and ophthalmologist, many times patient will complain of a one-side face pain. While washing, I'm having a burning sensation over it. So this nerve arises in the pons level. Okay. In the lateral aspect, if you see a thick structure like a rope, is a trigeminal nerve. This is a trigeminal nerve. On the lateral aspect of the pons, you will see midline structure is a basilar artery. On the lateral aspect, trigeminal nerve. The CSF will be bright. This is a cisternal segment. After it exits over here from the brainstem, this is a root entry zone. This is a commonest site for nerve root compression. This is a trigeminal nerve. Predominantly, it's a sensory, small motor component. It extends from lower midbrain to predominantly involving the pons. Okay, it has three divisions, like an ophthalmic, maxillary, and a mandibular division. All these three are sensory. Mandibular alone has got a small motor component. This is a trigeminal nerve, preganglionic segment. This is a Meckel's cave, as Dr. Lokesh showed a dilatation of the Meckel's cave in IIH. This Meckel's trigeminal nerve goes through the Meckel's cave, a trigeminal ganglion. If it is, sometimes schwannoma could happen over here or meningioma could happen here, which compress the trigeminal nerve. Vascular problems could happen over here, compress the trigeminal nerve in the cisternal segment. So these branches, these are the tiny branches which are very difficult to pick up. Any pathologies over here in the roof of the orbit, which could affect the ophthalmic division of the trigeminal nerve. This is a CT pictures which shows the enlargement of the foramen. Okay, so this is a pterygopalatine fossa. This is foramen rotundum. This mandibular nerve has different, trigeminal nerve has different branches. Ophthalmic division goes through the superior orbital fissure, whereas a maxillary division goes through the pterygopalatine, foramen rotundum and pterygopalatine fossa. Mandibular nerve goes through the foramen ovale. If any pathology like a dural fistula or anything which could compress the mandibular nerve, which could cause hemifacial pain. Trigeminal nerve has got central component and a peripheral component. This is the brainstem trigeminal nerve exciting. Up to 3 millimeter is the central nervous system component. Beyond that, it's a peripheral nerve. This is the commonest site for the neurovascular conflict. Many times, for this one-side face pain while washing the face or brushing the teeth, they are having pain, means vascular loop, predominantly superior cerebellar artery, is indenting or compressing the trigeminal nerve. What is the criteria when to call it as a nerve compression? There is some criteria. This is guidelines for assessment of the trigeminal nerve. One, it could be a normal without any compression, or it could be a contact by a vein, or contact by an artery, or indentation by an artery, or with displacement. This displacement or distortion by an artery causes a severe symptomatic pain. Particularly in hypertensive, hyperdynamic circulation, symptoms will be more. This is a trigeminal nerve. This is the axial plane. This is a heavily T2 weighted 3D sequence. In the lateral aspect of the pons, you will see a rope-like structure, gray in color, the trigeminal nerve. So this is indented by the superior cerebellar artery. If you reconstruct this in the sagittal plane, you could see this is the artery which is indenting. When usually neurologist, first they will put the patient on Tegretol. In spite of the maximum dose, if it is not responding, then the patient will referred for either RF ablation or a surgical neurovascular decompression. This patient was not responding to medical management. Then after surgery, you could see The indentation over the trigeminal nerve is completely, they had kept a just flap over there. This is a vascular loop. You could see this is a normal trigeminal nerve on the left side. This is an axial, heavily T2 weighted sequence. This is a normal trigeminal nerve on the left side. On the right side, you could see multiple dots adjacent to the rope. Vessels will appear as a flow voids. Particularly small vessels will appear as a dots. This is an indentation and mild displacement by the trigeminal nerve. So initially, even for all neurovascular conflict, this also like perioptic sheath prominence. Many patients, if you image for this audience over here, some would be having. Unless it is symptomatic, it need not be treated. Symptomatic also, first line is medical management. If it is not responding, minimally invasive like an RF ablation, or then finally comes a neurovascular decompression. Finally, the tumor, it's a schwannoma, can happen. As I said, schwannomas can happen any cranial nerve from 3 to 12. It is from the sheath covering the cranial nerve. This is a dumbbell schwannoma extending from middle cranial fossa to the intraorbital region. Through the ophthalmic division, it extends. This is a neurofibroma. You could see this is a normal, this is a coronal plane. If you remember this is a coronal plane, T2 weighted CSF, ventricle is bright. This is a optic chiasm. This is a cavernous sinus on either side. This is a normal internal carotid artery. Lateral to the internal carotid artery, on the right side, it is normal. On the left side, you could see a iso-intense structure. This is a neurofibroma. It could be a schwannoma or a neurofibroma. You need to give a contrast and differentiate. Sometimes you have to do HP, will need to differentiate. Any mass lesion in the brain or in the cisternal segment could compress the cranial nerve. This is a mass lesion. Okay, in the cistern, normally cisterns will not be like this. This is an enlarged, this is an epidermoid. This is a benign tumor. When the patient is symptomatic, it needs to be removed. Because this is a large tumor which is encasing the trigeminal nerve, it will be very problematic for the patient with severe pain. It's an epidermoid. It is not a glioma because it is not enhancing with contrast. This is also another case of an epidermoid. This is a malignant lesion from the nasopharyngeal region. This is a carcinoma. When you give a contrast, it enhances. It extends down to the infratemporal region also. This is a malignant lesion. CT will help in picking up the bony abnormalities. Next bony abnormal is petrous apex is located close to the trigeminal nerve near the Meckel's cave. If any problem in the petrous apex like a chondrosarcoma, this is a Gradenigo syndrome, petrous apicitis, which cause inflammation of the adjacent soft tissue. Compared to the right side, you could see enlarged soft tissue surrounding the petrous apex with enhancement. So next is abducens nerve. This is a false localizing sign. Longest nerve exits at the brainstem at the pons level. It is very difficult to appreciate like other cranial nerve. Abducens nerve will not be seen. It's a very small structure, thinner than a thread. Okay, it extends anteriorly. Okay, the problems which can affect the abducens nerve, since it's also a false localizing sign, many pathologies can present as a abducens nerve palsy. So starting from, it arises from the pons. How to differentiate this from a midbrain? It will not have a cleft. It will be slight indentation over the anterior surface. This is a pons. This is a cavernoma over the pons from the nucleus of the pontine level. Even the cisternal segment, any pathology is a meningitis. Okay. This is a pontine hemorrhage. Commonest hypertensive bleed is a pontine hemorrhage. Okay. Pontine hemorrhage. Any patient with hypertension should properly take medications. Otherwise, hemorrhage can happen. When it happens in the brainstem, it could be catastrophic. Patient will go in for ventilator and will not come out. Next is a cisternal segment. This is an exudate. Always, if you suspect infection, you have to give a contrast. Post-contrast sequence which is required is a T1 weighted. This is a post-contrast axial T1 weighted images shows enhancement of the cisterns. This cranial nerve could get stretched or compressed by it. Like this is a otomastoiditis. The entire middle ear cavity is destroyed with a soft tissue extending to the petrous apex. This is a diagrammatic representation of the cavernous sinus, pituitary, lateral wall cavernous sinus. Cranial nerve predominantly will be located in the wall. Abducens nerve will be located over here, internal carotid artery. So if this enlarges, aneurysm over here, it will compress the abducens nerve, or it could compress the cranial nerve over the wall. If any pathology over in the wall, like a cavernous sinus inflammation, Tolozan syndrome, it could cause the lateral, the wall of the cavernous sinus palsies, like a 3, 4, 5 cranial nerve palsies. This is a meningioma of the cavernous region. You could see enhancement of the meningioma. The only place CT is a aneurysm or a fractures or hemorrhage. You could see when you give a contrast, there is an intense enhancement. There is an internal carotid artery aneurysm of the cavernous segment of the internal carotid artery with erosion. This is a role for CT. Somebody was telling about a pituitary macroadenoma. This is a pituitary macroadenoma. When it enlarges, it compresses the optic chiasm. It encases the internal carotid artery. All the 3 cranial nerves in the wall of the cavernous sinus will be encased. So this patient needs to be, though majority of the time, even if the patient comes for cervical spine, when they find an abnormality, they image and give the diagnosis. So the patient can present with the bizarre symptoms, particularly in a cranial nerve problem. So complete imaging is required starting from brain, neck, and cervical spine. The pathologies could be all interlinked and associated. There is a mass lesion in the infratemporal fossa, which is extending intracranial. You could see the mass lesion over here involving the cavernous sinus, cavernoma of the cavernous sinus. This is a schwannoma of the trigeminal nerve. This is a malignant chondrosarcoma of the clival base. Next is a perineural spread. Why is it important? The patient from the stage of operability will become inoperable. Many malignancies will happen over the sinonasal region. It could extend along the cranial nerve intracranially. If it is picked up, patient goes from the stage 1 to stage 4 disease, from operability to inoperability. As I said, this is an era of evidence-based medicine. If we operate an inoperable case, patient will have got a significant morbidity, sometimes litigation, suing, many things can happen. So to avoid this, perineural, all sinonasal malignancies over the orbitofacial region need to undergo a contrast, look for cranial nerve involvement. These are the commonest malignancies which could extend across the perineural spread: squamous cell carcinoma, lip, palatine malignancies, nasopharyngeal CA. You will not know, the patient could present with the bizarre symptoms. You should assess the neck for the nodes, other pathologies. Complete holistic approach of the patient will pick up these abnormalities. You could see this is a perineural spread from a hard palate carcinoma. In the infratemporal region, the mass is there. It is extending into the cavernous sinus. Patient can present only with the diplopia. If we treat that with other, this progresses and becomes advanced stage, it is difficult. This is a CA maxilla, which is extending into the cavernous sinus. This is a normal cavernous sinus on the left side. This is on the right side. Next is a facial nerve. Facial nerve also arises from the pons. It circles around the 6th nerve nucleus. So any pathology in the pontine, like a pontine hemorrhage, can affect both 6th and 7th cranial nerve together. It has got multiple segments. It arises from the pons, goes along the internal auditory canal with the 8th nerve. And it has got different segments. Is a labyrinthine segment. Next is a geniculate segment, tympanic segment, and a mastoid segment. Pathology could happen at different places. Like the commonest abnormality in the facial nerve is a Bell's palsy, usually involves a geniculate ganglion. Sometimes enhancement can happen. Normally, in the case of a Bell's palsy, imaging is not asked. Only if it is not responding after atypical presentation, or if it is present for more than 8 weeks, then the imaging will be asked. What are the problems? Facial nerve could be affected. As I said, commonest is a ischemic event. Infarct or hemorrhage in the pons. This is an infarct in the pons. This is a T2 weighted. CSF is bright, T2 weighted sequence. Always, if you look into T2 or a stir, pathologies will be better seen for brain parenchymal problems. Okay, this is an infarct in the brainstem. As previous speaker told, demyelination, particularly in a pediatric or infective etiology, demyelination can happen. Vascular thing is a cavernoma of the pons, which could affect both 6th and 7th cranial nerve. Inflammatory process, viral neuritis like a Bell's palsy, you could see the enhancement of the facial nerve. There is no enhancement on the right side, there is enhancement on the left side. Routinely, it is not done. Only for atypical presentation only it is done. Okay, for all meningitis could affect the cranial nerve. This is an X-rays. Though we are speaking about eradicating tuberculosis, still it's more prevalent in our country. We should have a high suspicion for atypical presentation for tuberculosis and sarcoidosis. Next is the 8th nerve, schwannoma. This is a 7th nerve schwannoma. You could see an enhancement. The smaller tumors could be missed unless we give a contrast. This is a schwannoma intracanalicular component. This is a facial nerve schwannoma extending along the mastoid segment. The important thing, skull fractures could affect the facial nerve and eighth nerve. Patient could end up in total hearing loss, facial palsy. This is a fracture of the mastoid portion extending along the petrous bone. We'll skip this. These are the vascular loop. This is a facial nerve which is compressed by the vascular loop, anterior inferior cerebellar artery. Blood vessels will appear as a flow void. Nerves will appear as a gray matter structure. This is a compression of the facial nerve which could cause hemifacial spasm. This is a Bell's palsy. Sometimes you could see enhancement of the facial nerve of the geniculate ganglion level. Skip this. Next, the vestibular cochlear nerve. Eighth nerve is responsible for hearing. It has two components. One is a vestibular, which is responsible for vibration, other senses. Next is a cochlear nerve for hearing component. Cochlear vestibular component is located posteriorly. Cochlear component is located anteriorly. It arises, the nucleus arises from the pons. Coming to it arises, pathology arises from congenital to neoplastic etiology. Congenital means it could be aplastic or hypoplastic. This is a normal 7th, 8th nerve internal auditory canal. It should be seen like this well on a CT. If it is absent, it is dysplasia or a aplasia. This is a congenital abnormality. This is a complete aplasia of the cochlear nerve. Cochlea itself is not seen. So no, there is no role for like a hearing implant or anything in this patient will not help. This is a complete aplasia of the cochlear nerve. This is a bilateral 7th, 8th complex is absent. The bony canal will be atretic or will not be seen at all. Another pathology is a schwannoma, which we call it as like a foot sign, ice cream cone appearance. This is the base of the cone. Ice cream will be at the top. This is ice cream cone appearance. When you give a contrast, there will be enhancement. There could be hemorrhage also. These patients can be asymptomatic until it rises to a big level. Sometimes they can present with a occasional earache or anything if you have eye suspicion, which could picked up. So next 9, 10, 11th and 12th cranial nerve, I'll go fast because majority will be where you come across is the Horner syndrome. I'll show some of the lesions. Okay, this is a schwannoma of the jugular foramen. CT is good for bony abnormalities. This is a normal jugular foramen on the left side. Here, right side, you could see significant enlargement of the jugular foramen. The soft tissue component, when you give a contrast, there is showing enhancement. This is a schwannoma of the jugular foramen. It could present even as a Horner syndrome. This is a vagal schwannoma. You could see it is extending from above down. This could also present with a Horner syndrome with a ptosis, meiosis, anhidrosis. This is the 11th nerve, spinal accessory nerve schwannoma. So important neoplastic pathology in the cranial nerve is a schwannoma. This is a glossopharyngeal neuralgia, sometimes like a trigeminal neuralgia. This could also be intimidating. Finally, the 12th nerve. 12th nerve exits from the medulla, exits anterolaterally through the hypoglossal canal. The important problem, either it could be a lateral medullary syndrome, medullary infarct, or it could be a neoplastic lesion. This is a neoplastic lesion from the hypoglossal nerve. You could see a dumbbell shaped from the canal with extracanalicular component with atrophy of the tongue. Hypoglossal nerve usually supplies the tongue. If it atrophies, it becomes fatty infiltration. This is a hypoglossal nerve schwannoma. Next, a small spotters. Since you being an ophthalmologist, retinoblastoma. What do you want to do? Enucleate? Huh? MRI for extension. Sorry, unfortunately. What is this image? Ultrasound. Okay, this is one of the easiest tool, less invasive. This is a retinoblastoma. You want MRI for extension. How do you treat, madam? Remove the eye. This is MRI. What is this plane? Coronal. What is the sequence? T1. Good. CSF is bright. At least job is done. This is optic nerve. Okay. This is a coronal plane. You could see a retinoblastoma. Since I being an interventionist, this being an intra-arterial chemotherapy for retinoblastoma. Okay. Into the ophthalmic artery. This is post 4 weeks. This is post follow-up. This is child. Pre-procedure, post-procedure. That white eye reflex itself is significantly gone. Okay, multiple times this could be done. We could preserve the eye. Sometimes vision also could be preserved for retinoblastoma. Okay, this is after 2 cycles of IAC. Next case is a 25-year-old teacher by occupation, met with a road traffic accident. What is the diagnosis? CCF. Postgraduates, what are the types of CCF? What are the types of keratotic cavernous fistulas? How many types are there? So what is this, CT or MRI? Huh? CT or MRI? CT scan, okay. This is CT scan, reconstructed images, axial plane, this is a sagittal plane, okay. We have put arrows. This is a dilated superior ophthalmic vein. This is a dilated cavernous sinus. This is middle cerebral artery, dilated cavernous sinus, dilated superior ophthalmic vein. Whenever you see any patient present with a proptosis, if you put your stent on the eye, there will be a bruit in front of the tragus or in the mastoid region also. This is a dilated cavernous sinus with a complete, because of skull base fracture, complete transection of the internal carotid artery. So this is complete transection of the internal carotid artery. The patient had presented with a diplopia, lateral rectus palsy. Okay, this is post embolization. This is before, this is after. The cranial nerve palsy we will not be able to correct. If it is not, there is no role for medical management or surgical management for keratoconus fistula. Why we need to treat? To prevent visual loss, to prevent intracerebral hemorrhage, to prevent death. These are the 3 reasons to treat CCF: to prevent visual loss, to prevent intracerebral hemorrhage, and death. So if you treat before vision loss happens, we could preserve. Cranial nerve palsies, we will not be able to correct. This is, okay, this is internal carotid artery. This is an angiogram. This patient presented with a ptosis. Ptosis, diplopia. This is an internal carotid artery aneurysm, okay? This is seeing from the front. This is seeing from the side, lateral. So for these type of aneurysms, when they present with the ptosis, it's a warning sign. If you treat early, the cranial nerve palsy will recover. Some patients can present with a rupture with a keratoconus fistula. When these aneurysm ruptures, they can present as a keratoconus fistula. If it is beyond the ophthalmic segment, patient can present with a subarachnoid hemorrhage in the dura. So this is post stenting and coiling, the complete thrombosis of the aneurysm. This is a persistent trigeminal artery variation. This is a post treatment. You could see the complete thrombosis of the aneurysm. The patient's pressure effect will put the patient on a short course of steroid. Cranial nerve palsy is near totally resolved. As Dr. Lokesh or Dr. Ambika was speaking about dural sinus thrombosis and venous hemorrhage. So one of the few of the slides which showed were dural fistulas. One entity, one important problem which is missed is a dural fistula. Dural fistula is nothing but an abnormal connection between an artery and a vein. Usually post-dural sinus thrombosis, it can happen, or majority of the time, patient could be asymptomatic for dural sinus thrombosis. Patient would not have met the doctor at all. Mild headache, pharmacist would have given a Calpol, it would have subsided. Sometimes later, he present with the seizures, diplopia to the ophthalmologist. When you evaluate, patient could have a papilloedema, other things. When you image, unfortunately, now only I added these images. When you image, there could be a small prominent flow voids adjacent to the transverse sinus or a sigmoid sinus, which is called as a dural fistula. If this dural fistula, why we need to treat? This also to prevent visual loss and to prevent intracerebral hemorrhage. This is external carotid artery injection, filling the transverse sinus. Normally, external carotid artery should not fill the sinus. This is a dural fistula, which could present with a papilloedema, diplopia, intracerebral hemorrhage. This is another patient with a post-traumatic. This is how it is done. We inject like a liquid Fevicol and a coil. This is post, which some dramatic result which could give. Sometimes I get a referral for ophthalmic artery occlusion, whether you could recanalize it. There is no role for intervention for ophthalmic artery occlusion. If ophthalmic artery is occluded, it's gone. So if you pick up amaurosis fugax, transient loss of vision at an earlier stage, what are the things you need to do? The important thing is that you need to do a neck vessel Doppler or a neck vessel imaging. Carotid stenosis, if it identified early, like in a signs of transient ischemic attack, if it is picked up, you could avoid. Once the ophthalmic artery is occluded, we will not be able to recanalize. Many times I get a call, ophthalmic artery is occluded. Can we open it up with a stent retriever or put some medications? Ophthalmic artery is a very small vessel. If you touch, it will go. It will get occluded. So the no role for ophthalmic artery occlusion, recanalization. Only if you pick up at an earlier stage, what are the things you need to do? You need to assess the neck vessel. If it is carotid stenosis, you can revascularize. This is post-stenting, which could prevent the patient should be on antiplatelet lifelong. To sum up, regarding cranial nerve imaging, about this talk, if you know basic MR interpretation, axial images, coronal images, axial, coronal, then T1 and T2. T1 CSF will be black in color. T2 CSF will be bright in color. For orbit or cranial nerve imaging, you need to use for a high resolution 3D CIS sequence or a 1 mm imaging. Okay, stir coronal is good for evaluating the orbit. For optic nerve, if you remember target sign, nerve will be gray in color, surrounding CSF will be bright. In an optic neuritis, it will be lost, everything will be bright in color. Everything will be similar to a CSF. If you suspect infection or if your cranial nerve palsy is so significant, if plain MR is negative, ask for a contrast. Anatomy is the key to identify all pathologies. CT sometimes could be complementary. Always MR is a modality of the choice. I think this is an important sequence which you need to remember. High resolution or a 3D CIS sequence. Okay. This is a benign papilloedema. I'll skip. So it's only a team effort. Now with the era of so many litigation, medico-legal problem, earlier work as a team. If you have any doubt, ask for your senior opinion, neurologist, other referral, then it will be better. Patient would be better. If you have a better treatment for the patient, you would get more referral. Rather than being a single player winner like a tennis, we can work as a team and produce good results. Thank you.